Welcome to another episode from the Veterinary Research Channel. Today, we're diving into a recent study published in Veterinary Surgery looking at diagnostic methods for a common cause of urinary incontinence in young dogs, ectopic ureters. These are anatomical abnormalities where the tubes carrying urine from the kidneys, the ureters, don't properly connect to the bladder in the normal position. They can open further down the urinary tract, like in the urethra or vagina. Diagnosis is crucial because the treatment depends on the specific anatomy, particularly whether the ectopic ureter is intramural or extramural. Intramural means the ureter enters the bladder wall normally, but tunnels within the wall to open elsewhere, while extramural means it bypasses the bladder entirely and opens into the distal urinary tract.
And this distinction is really important because a minimally invasive procedure called cystoscopic laser ablation is a good option for intramural ectopic ureters, effectively creating a new opening in the bladder. However, this laser procedure is not suitable for extramural ectopic ureters, and attempting it can risk perforating the urethra. So, getting an accurate diagnosis before or during surgery is vital. Several imaging techniques exist for diagnosing ectopic ureters, including older methods like excretory urography using radiographs or fluoroscopy, ultrasonography, and a more advanced technique called computed tomography excretory urography.
Computed tomography excretory urography, or imaging using computed tomography with contrast medium, is generally considered superior to other methods because it provides detailed images of the ureter morphology in multiple planes, offering enhanced anatomical information. Despite these advantages, it's known that computed tomography excretory urography isn't always perfect at telling the difference between intramural and extramural ectopic ureters. It can also be difficult for it to pinpoint the exact location where the ureter opens. Specialized techniques like using maximum intensity projection or repeated scans can potentially improve accuracy, but they have downsides like needing special equipment or giving higher doses of contrast agent or radiation. Most veterinary surgeons rely on regular computed tomography excretory urography for diagnosis and surgical planning. This study specifically investigated the diagnostic accuracy of routine computed tomography excretory urography by comparing its findings to those from cystoscopy, which involves using a scope to visualize the urinary tract, in dogs suspected of having ectopic ureters. The goal was to understand how well computed tomography predicts the anatomy and the opening location compared to visualization with cystoscopy. The study hypothesized that computed tomography would have less than 90% sensitivity in predicting ectopia and would be less accurate at predicting the opening location compared to predicting ectopia itself.
This was a retrospective study reviewing the records of 35 client-owned dogs referred for suspected ectopic ureters who had both computed tomography excretory urography performed and then rigid cystoscopy. In some cases, the minimally invasive laser procedure was also performed during the cystoscopy. The researchers collected data including sigmoid, degree of urinary incontinence, body condition score, weight, level of colon distension seen on the imaging, and the findings from both the computed tomography excretory urography reported by board-certified radiologists and the findings during cystoscopy. They then used statistical analysis, specifically receiver operating characteristic analysis, to compare how well the computed tomography predictions matched the findings from cystoscopy. They looked at whether the ureters were predicted as normal or ectopic, and whether they were intramural or extramural. They also evaluated how well computed tomography predicted the location of the ureteral opening, categorizing locations based on whether they were in the normal trigone area, the bladder sphincter area, the urethral sphincter area, or further down the urethra.
Looking at the results for diagnosing the type of ectopic ureter on a pre-ureter basis, the study included 70 ureters from the 35 dogs. Computed tomography predicted 67 of these as either ectopic or normal, with 3 being inconclusive. Comparing these predictions to the cystoscopy findings, the ability of computed tomography to correctly identify a normal ureter as normal, indicated by the negative predictive value for ruling out ectopia, was only 50%. In contrast, the ability to correctly identify a truly ectopic ureter as ectopic, the positive predictive value for any ectopia, was 91%. Overall, computed tomography correctly identified a normal and an intra- or extramural ectopic ureter in 13 out of 26 normal cases, 50%, and 32 out of 41 ectopic cases, 78%, respectively. This suggests that computed tomography findings alone did not accurately predict the anatomy of the ureters in a conclusive manner. The study's findings regarding computed tomography diagnosis of ectopic ureters align with some previous information, confirming that computed tomography is a reliable imaging method for diagnosing or ruling out the condition. However, similar to this study, Previous research also highlighted limitations of computed tomography in diagnosis and suggested that cystoscopy is superior when compared against surgical or post-mortem findings. One prior study found computed tomography to have high sensitivity and specificity for diagnosing ectopic ureters, 91% sensitivity and 100% specificity, but the negative predictive value was only 57%. This is consistent with the current study's results and reinforces that computed tomography cannot be completely relied upon solely for diagnosing ectopic ureters, especially given the 43 to 50% chance of diagnosing a truly ectopic ureter as normal.
The distinction between intramural and extramural ectopic ureters is particularly critical for treatment planning, especially regarding the minimally invasive laser procedure. The study specifically evaluated computed tomography's ability to distinguish between these two types. For identifying extramural versus intramural ureters, the sensitivity and specificity of computed tomography were 29% versus 65% and 97% versus 71%, respectively. This indicates a poor sensitivity for correctly identifying extramural ureters, 29%, but a high specificity, 97%, meaning if computed tomography says it's not extramural, it's usually correct. The discussion points out that in ureters identified as intramural ectopic by computed tomography, only 65% were actually intramural according to cystoscopy. Conversely, 71% of those identified as not intramural on computed tomography were indeed not intramural. A concerning scenario arises if computed tomography incorrectly predicts an extramural ureter to be intramural, as attempting the minimally invasive laser procedure in such a case carries a risk of ureteral perforation, particularly for less experienced surgeons. While this study found it was more common for intramural ureters to be falsely predicted as extramural, 4 ureters falsely predicted as intramural and 1 predicted as normal were found to be extramural during surgery. Surgeons must be aware of this potential discrepancy. The study highlights that anatomical complexity, close proximity of structures, and challenges with contrast timing can obscure the diagnosis. Ureters without significant dilation that run within the bladder muscle layer can falsely appear to connect normally, making identification difficult, especially near the trigone region. The curved nature of the ureter and the limited time to observe the contrast agent passing through the ureter during peristalsis also add to the challenge. Furthermore, collecting adequate contrast in the bladder during prolonged scanning can hinder accurate identification of the ureter's contrast jet.
Beyond identifying the type of ectopia, the study also tried to figure out if computed tomography could accurately predict the location of the ureteral opening, which is also useful for planning the minimally invasive laser procedure. While the opening is often visible with cystoscopy, it can be hard to find if it's narrowed or located very close to or within the bladder sphincter. Being able to predict the location beforehand would be beneficial for surgical efficiency. However, when the study compared computed tomography predictions of specific orifice locations, normal trigone, bladder internal sphincter area, ureteral internal sphincter area, and further down the urethra, with the cystoscopy findings, the sensitivity and specificity were low across all locations. Predicting openings in the sphincter areas seemed particularly challenging for computed tomography. The sensitivity for predicting location A, bladder sphincter area, was 0%, and for location B, ureteral sphincter area, it was only 15%. Even simplifying the locations into just 2 groups, ectopic, ureteral sphincter area and urethra, and non-ectopic, normal trigone and bladder sphincter area, only resulted in moderate sensitivity and specificity, ranging between 78% and 83%. This suggests that surgeons cannot rely on computed tomography to accurately predict the precise location of the ureteral opening and must look closely at the urethra-bladder junction during the scoping procedure. To the author's knowledge, there isn't much other research specifically determining how accurately computed tomography can predict the ureteral opening location.
While much of the analysis focused on individual ureters, surgical decisions involve evaluating both ureters in a dog. The study also assessed how well computed tomography predictions of both ureters in a single animal aligned with what was found surgically, looking specifically at whether the predictions suggested the minimally invasive laser procedure would be beneficial, not beneficial, or contraindicated. From this perspective, the ability of computed tomography to correctly predict if at least one intramural ectopia treatable by the laser procedure was present resulted in a sensitivity of 82% and specificity of 43%, with an overall accuracy of 74%. For predicting at least one extramural ectopic ureter, where the laser procedure is contraindicated, the sensitivity was 33% and specificity was 97%, with 91% accuracy. The accuracy for predicting normal ureters, meaning the dog wouldn't benefit from the laser procedure, was 83%, but the sensitivity was only 50%. These results showed variable accuracy when looking at the bilateral predictions from a surgical planning standpoint. The findings indicate that about 74% of dogs diagnosed with intramural ectopic ureters by computed tomography excretory urography would indeed benefit from the laser procedure. However, 26% would not, because the computed tomography prediction of intramural ectopia didn't match the surgical findings. The ureter was actually normal or extramural. Similarly, while computed tomography was 91% accurate at diagnosing extramural ectopic ureters on a per-dog basis, there was a 67% false positive rate and a 2% false negative rate. This means many dogs predicted to have extramural ectopia might actually benefit from the minimally invasive laser procedure, while a small number could be at risk of urethral perforation if the procedure is attempted based on the prediction. Furthermore, only 33% of dogs diagnosed as normal by computed tomography actually had normal ureters, with 67% having ectopic ureters. In this study, 4 dogs predicted to have bilaterally normal ureters by computed tomography actually had ectopic ureters that could be treated with the laser procedure.
The study also investigated if certain factors like age, body condition score, body weight, incontinence score, or colon distension were associated with the discrepancies between the computed tomography predictions and surgical findings, but none of these factors were found to affect the accuracy of the computed tomography diagnosis. The authors had anticipated that body condition or colon distension might decrease accuracy due to the complex anatomy and limited study region, but this wasn't confirmed in this study's population size. It's important to note some limitations of the study, including its retrospective nature, the relatively small and not entirely uniform group of dogs, and a lack of standardized protocols for performing the computed tomography scans. Different radiologists interpreted the images, and the specific timing of scans after contrast administration wasn't consistently documented for all cases, which could potentially affect the accuracy of identifying anatomical structures. The incontinence scores were also based on retrospective client descriptions rather than a standardized assessment. Future prospective studies with larger populations and standardized protocols are needed to confirm these findings and potentially identify other factors influencing the accuracy of computed tomography for diagnosing ectopic ureters.
In conclusion, while computed tomography is a useful imaging method for visualizing anatomical structures and investigating upper urinary tract conditions, this study's findings confirm it cannot be relied upon as the sole method for accurately predicting the anatomy of ectopic ureters in dogs. It showed variable accuracy in predicting both the overall anatomy and the specific type of ectopia, intramural versus extramural, as well as the location of the ureteral opening. Based on these results, utilizing both computed tomography excretory urography and cystoscopy together is recommended to maximize the chance of correctly identifying the ureteral anatomy. Using both diagnostic tools will better assist surgeons in making clinical decisions and providing appropriate advice to pet owners.
Thank you for listening to the Veterinary Research Channel. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.